Hello and welcome to Elderly Health. My name is Nicholas Torres and I'm the Executive Director of the network Towards Unity for Health. Thank you everyone for joining us on this important topic. We may be joined by our moderator Noeline in a few minutes, and if so, I'll turn it over to her. Please remember that this symposium is being recorded and will serve as a source of information when global thought leaders convene at the network TUFH's Global Solutions Challenge in September to collectively design, test, and reach consensus on global recommendations on social accountability, interprofessional education, population health, and community approaches to engage and serve remote and rural migrants or refugees, indigenous, women, and elderly populations. Just for our participants, if you have questions or comments, you can either submit them in the chat box or you can unmute yourself and at a pause, ask a question or provide a comment to some of the questions if you have any. So I'd first like to provide some background context for our participants. The network TUFH advances universal access and equitable healthcare, which we believe is a human right, by helping coordinate, share, and build capacity between and within academic institutions, health systems, and communities. By serving as a global connector between these three sectors, we are fostering the creation of new knowledge and collective solutions, building capacity within institutions and systems, and informing regional and global policy. TUFH aims to create a well-coordinated collective repository of innovations, best practices, and research that educates, builds capacity, and informs systems and policy coalitions and leaders towards rich discussion and debate in order to improve upon regional and global health policies. To provide some context to our conversation today, we know that populations around the world are rapidly aging. Aging presents both challenges and opportunities. It will increase demand for primary health care and long-term care, require a larger and better trained workforce, and intensify the need for environments to be made more age-friendly. Yet these investments can enable the many contributions of older people, whether it be within their family, to their local community, or to society more broadly. Societies that adapt to this changing demographic and invest in healthy aging can enable individuals to live both longer and healthier lives for societies to reap dividends. So I'd first like to welcome our panelists, who will provide a more in-depth introduction to themselves and their work. So Riddhi Goradia, and you can correct my pronunciation, so welcome. She's a physiotherapist, assistant professor from the Department of Community Physiotherapy at Somaiya College of Physiotherapy in Mumbai. And we have Fitriana Mawardi, who's a family medicine and community department for medical faculty at Gadjah Mada University. So welcome both of you.
Thank you.
And so Fitriana, how about I turn it over to you and you do the first introduction? And if you would like to take 3 to 5 minutes to introduce yourself, your organization, your work, and your work related to elderly health.
Okay. Thank you, Nick, and hello, everyone. Good morning, good evening, or maybe good afternoon, I don't know. But absolutely, in mine is good night. And then let me thank you for the time for me to introduce myself, that I'm a medical doctor who work as a general practitioner and junior staff in community and family medicine department and Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, Yogyakarta, Indonesia. And furthermore, I'm also an executive manager of community and family healthcare with the professional education unit as a featured program in my faculty. And my field of specialty is a community health, especially in prevention and management of metabolic disease, geriatric metabolic disease, in the professional education, in the professional collaboration practice, biopsychosocial, family health, maternal health, or community. And my work involves curing patients, preventing community health problem, research executing project of community development, communicating with the stakeholder in Yogyakarta, Indonesia. And then now that the Dean gave me responsibility as a leader in the geriatric in the professional education piloting project for the physical training, and this is related to the academic health system. And then for the geriatric, and the director in my institution, Gadjah Mada University, Yogyakarta, Indonesia. we will develop about geriatric healthcare clinic center, and then it needs like interprofessional collaboration practice. The pilot project to do or to develop the curricula for the clinical training for the health students in our institution for developing in geriatric care. That's all. Thank you.
Great, thank you so much. And now I'd like to introduce Riddhi, and let me unmute you.
Okay. So, hello, I'm Riddhi Goradia. I'm a physical therapist, physiotherapist. I mean, it depends from country to country how it is introduced. So, I've done my master's in community physiotherapy, where geriatric physiotherapy is a part of it, a domain of it, and I'm working as an assistant professor in Somaiya College of Physiotherapy, as Nick introduced before, and also I'm pursuing fellowship in geriatric physiotherapy. Coming to my work experience and what work I'm doing is basically I am handling the geriatric rehabilitation department in Somaiya Hospital and Somaiya College of Physiotherapy, where we have indwelling elderly, the ones who are staying in nursing homes and the ones who are coming to OPD. So basically, designing a rehab protocol, as we know, wellness is more important and we want them to have improved quality of life. So designing a protocol for them. Also, I am active working as in an NGO who works for a person with disability who wants to pursue parasports. So the foundation name is Aditya Mehta Foundation. So person with disability and geriatrics going hand in hand. So my research topic was on balance and coordination evaluation in geriatrics. And for my fellowship, which I'm currently pursuing, I'm interested in doing the keywords of assistive technology and geriatrics. Thank you.
So welcome both of you, and welcome to all of our participants. To get our conversation started, I wanted to reference us back to WHO. WHO, the World Health Organization, and they discussed 10 priorities of our decade of action in healthy aging. And 2 of the priorities are focused on the collection of better data and the promotion of research. So we all know that if we have data and research, we can look towards the future and improve could it be curriculum or the education or the services for the elderly. So I wanted to put it both to you, both of you, and then we will open it up to our participants. If you can discuss your current knowledge of the data and research that you're using or that may be available globally that informs global healthcare for the elderly, and using maybe a couple case examples. So Fitriana, would you like to go first?
Okay, thank you, Nick. For the current data and research that informs global care for the elderly, as you should know that in 2010, and estimate about 424 million people were aged about 65 year older, or equal to 8% of the population. And then by 2050, this number is expected to nearly triple to about 1.5 billion, representing 16% of population. And in the worldwide, the problem of elderly, such as dementia, non-communicable diseases as heart disease, cancer, and diabetes, it will increase related to the increasing of the population in elderly. And Indonesia, especially in my country, is one of the aging country with the district in my hometown. Yogyakarta province has the highest number of elderly based on the Indonesian National Survey data. And the number of elderly in Indonesia is about 22.5 million, or about 8.96% of the population. And that will be increased in every year in my hometown, Yogyakarta. And in Indonesia, elderly health problems such as immobility and degenerative disease is high, and this is I got from based on the data, basic health research from Indonesia Ministry of Health, as that program, the most health problem in elderly was the most high disease is hypertension cases. It's about 57.6%. And Indonesia concern for elderly care through political support of policymaker, NGO, community and religious leaders, as well as an expert in aging, in efforts to improve older person welfare and create informal support for older persons by maintaining family and community support for older population and create formal support for older persons by increasing improvement in health services and development of system in protection and social security for older persons, establishing the enforcement of older person institution through improving intersectoral cooperation at national and international levels. And so role of an older person in family life as well as nation and style. That's all from.
So from what I think, from I understood what you said is data is being used to both improve services, but also influence policy at a sort of at the national government level towards that. Any thoughts on where the gaps in the data that is needed? Because WHO talks about there needs to be better data and promotion of better research. So in your experience, where are the gaps in that data and that research that you would like to see improved?
It is about the gap of data is because in elderly there is a complexity about the disease. So and then they need like a comprehensive care for caring of their health like that, and that's why that our government is really concerned about elderly because it increased so fast in my country and especially in my hometown Yogyakarta district because in my hometown the number of the elderly is increased per year. It's always increased per year because my hometown is there is a community of the retirement persons like that.
Great. Well, thank you. So, Riddhi, let me turn it over to you and say with the same question.
Yeah, as Fitriana already mentioned about the data which was proposed in 2010, but along with it, what I would like to add is the World Report on Aging and Health, which WHO had proposed, which was in 2015, which stated that the life expectancy has increased, but then what kind of life what we are expecting, like that we need to have disability free life expectancy, which is lacking. So we need to reduce the disability free. I would say there shouldn't be any disability. So that is what the research said. What he said, France is the leading population aging, which shows us that the geriatric population has increased a lot, and now each and every country in the world is facing through that. So as the population age, demographic details shows us that. So basically, it's going through population aging, and we need to keep a control on that. And along with it, as we know that population is aging, it showed that the policy making has to be really strong. So there is lack of policy across the globe, or maybe people are not aware, especially in developing countries, where the policies needs to be explored and taken into consideration. According to WHO, that report also mentioned that we need to add health to it, what is not the current trend, and that has to be taken care for. Also, as we know that age-friendly environment was one of the lacking factor, which is causing an issue and which is causing global crisis. See, the global crisis is being faced by each and every, be it UK, US, even the developed nations. So that needs to be taken care of. As in 2010 and 2011, research says that there was lack of funding for people in the geriatric population, and which was a burden on the healthcare system and ultimately the population. So a strong policy on that has to be formed. And the number was more than 8 lakhs, where they 60 plus people were not funded for their healthcare, be it for taking care of themselves. And also now, where the systems are changing, where people are staying in a nuclear family, that there is no caretaker, so the caretaker burden has also increased, eventually the health affecting the health of the senior citizen. As we know that US is also heading towards caregiving cliff. So again, the burden on caregiver is increasing, and also the care which a person needs in a family is not well expected. So, and again, the rise, the most common, in India, according to ICMR report, which says that the most common cause of morbidity in Indian population is because of visual problems.
Thank you so much, Riddhi. And now I'm going to turn it over for Noeline, who's our moderator, and we'll continue moderating and provide commentary and continue with the questions. Noeline?
So, and I thank the moderators and whoever has joined in. My perspective on elderly health, if I could give an example like the other two panelists have given, mine will mainly focus from an education point of view in making, students as well as carers within the community health carers more aware about the elderly and the kind of services that they need to use. So if you could permit me, I could just give a brief about the Elderly Care Task Force within the network and what it's been doing, just as a summary. Its main focus is to promote ways in which students learn to value older persons as a community of individuals requiring a care delivery system characterized by responsiveness and consideration of the collective as well as the individual. And I think the previous panelist has highlighted these as points that were actually pointed out by the WHO report. So through the years, we've tried to involve students as well as medical educators in activities at various universities that could promote this view of trying to give attention to this elderly, because oftentimes the curricula, as the first panelist was speaking, were not catering for the elderly, and it's something that we can build on, for the future. The other aspect I would like to present is the issue of our own setting on the African continent. The reports show that the elderly are increasing, but they are this is a setting that is with limited resource, with change of family structure, and that causes concern as to what's going to happen to these individuals moving forward. When you bring in aspects of research, we have a challenge in having the appropriate instruments for assessing cognitive impairments, which is the commonest challenge that these elderly people may face next to depression. And yeah, a lot of work needs to be done moving forward in these specific areas. So I'd like to hear from the panelists if they face a challenge, especially in regards to, say, research. We'll talk about caregiving, but I think that's kind of universal, both within the health system as well as within the homes. But I would like to hear their views about trying to find out what problems the elderly face and how to address them within their specific communities.
Okay, so in my country, for the elderly or geriatric problem, is about based on the psychology beside the physiology, and they feel like depression and loneliness, and then after that they got dementia like that, and then because they live alone and their children not in the same house like that. So they have no one to talk to. And then especially in the urban level, the elderly, the activity is really monotone. They just join in in my country, because we all almost all the population in my country is a Muslim. So we have like activity like we call pengajian like that, and geriatric community who's Muslim always active in their religion activity like that. And if we're not Muslim, yeah, and just for urban, but it's quite different in the geriatric population, geriatric community in rural, because they can do more activity and variety activity to kill the time and to kill their loneliness like that. So that's why like in quality of life in elderly in urban is not as good as in elderly in rural like that. This is in my country, it's happened like that. So yeah, because in urban the children is get very busy with their work, with their job, or with their duty, and then they have no time to talk to their parents or their mother or their father like that. And the activity for the elderly is not a variety, so that's why their health is become a decrease like that. So so that's why it can arise so many risk factor of the disease, especially in non-communicable disease like that in my country.
And those, I think, the points that Fitriana has put across may be the same in a, across the globe. That's what's happening with this. But I want to evaluate things in that particular community. You have challenges in, from a research point of view, if you have challenges in having the appropriate instruments for assessing these kind of things in order to be able to address them. Within your community, do you have any challenges with instruments that you may need for research in being able to document the challenges that you've just listed?
Yes, the challenges, especially in my country, because like in WHO, there is like a endorsement for all the health institution. I think it is for the World Health Institution around the world, that we have to, to make like comprehensive care for the elderly. So in my country, we can do that through the collaboration practice. And that's why that in my country, we develop their comprehensive care through the interprofessional or multi-professional collaboration practice. And we develop the tools, we try to develop the tools to assess that implemented of the comprehensive care, or to assess the collaborative practice care like that. And then we we redesign about from the WHO to assess the high quality of life in elderly. We redesign that and then we can use that based on in our culture, based on for my country like that.
So Riddhi, we're asking a question as to whether there is, in the points that you tried to point out before, which are kind of universal, about the elderly having decreased disability, rather increased disability, and yet the services that are being offered for them within their areas may not, be targeting that. Is there any challenges in your setting as regards to that specific point on disability and age-friendly services?
So, as I said, being from developing country like India, where the access to even healthcare is an issue. So, getting access, even getting out of the room itself becomes an issue where a person has to climb stairs. As we know, because of physiological changes, there are a lot of issues with the muscle power and the activities. They feel difficult to walk or maybe climb stairs. So, that is the place where it starts hindering their activity or their community participation, which pose a problem. As Fitriana already said, that there are issues where they don't have enough time to spend with their kids or their family members, the loneliness and depression and cognitive decline. Along with this, there are physical issues as well. So together with mental and physical health, both needs to be taken care of. And the issues which currently faces basically because of that knee pain or back pain, we know that because of maybe musculoskeletal problems, or as Fitriana said, because of community ambulation becomes an issue. And because of maybe communicable disease or non-communicable disease, they are staying, but their quality of life is affected. So as statistics says that majority, especially in India, majority of people are staying in rural. So the primary healthcare needs to be very strong to support where, right, even the Anganwadi workers or Asha workers, which works in rural areas where primary health centers are there, needs to be strengthened, which is lacking. And also access to even the medicines or assistive devices becomes an issue. So they are staying because they want to, because they have to stay, but then again their quality of life is affected.
Right. So there are lessons we can learn from some communities that have had the elderly and where governments have tried to have an input. I could give examples of two places that I have been to before. For example, I got to learn that in the UK they have a ministry of loneliness. So this ministry focuses on elderly individuals to try and see how they can decrease on that loneliness, which we know usually ends up putting these elderly individuals at risk for things like depression and suicide. But I don't know of any other country where they have, say, within the health system. Because one of the recommendations you had mentioned from the report was the issue of different communities, or one of the participants in here wanted to see if at all there's anything that has been done to the health systems to adapt for this increasing number of individuals who are older and lonely. So I know that happens in the UK. In Colombia, I know that they get out older persons to meet, I think, twice a week to involve themselves in kind of exercise within the community. And this is not, within the city center. They meet in groups, but that's not something that is kind of universal as yet. Do other members have any examples of things that we could try to advocate for in trying to improve elderly care within the community?
Thank you for all those comments. I'm from Uganda, but I visited Ireland and we visited the health center, and they had an arrangement whereby in the community they find people that are not employed, and they give them like 1 hour of employment per week through the Ministry of Health. And these people visit the elderly, like one person may have a dedicated elderly person that they visit. And these, because the health workers are few, these are points of contact between the health system and the communities where the elderly people live. And so these people not only give them, support the elderly in kind of the issues to do with the mind, to avoid them being lonely, and also making sure that they don't only do that, but also make sure that their environment is good, make sure that if there are any urgent issues, health issues, they can report to the health center. So they are using the communities to reach out to these people, but at giving them really minimal time. And what happens eventually is these people kind of get attached to these elderly people, and they actually give more time than what they are paid for. And I found that very, very interesting. It's a good way of approaching it, so that these people have contacts that can lead them to the health centers if they have health issues. And if they don't have health issues, at least they have people that can care for them and bring them closer to other members of the community.
Okay, so that's interesting. And Riddhi here suggests that taking charge of their own health and sensitizing them as to why it is important. And this would work well to sensitize everyone, not only the elderly, about their health, but I guess emphasizing the issues that, commonly affect them. The challenge usually comes in how they should access care for those things that they've found within themselves, especially for resource-limited settings. But when people grow older, whether you have resources or not, then it becomes a challenge as to, they may not even know, especially when the cognition goes, they cannot really, do this very well. And I guess apart from relying from community or volunteers, we remain with a big problem for the future. Does anyone have thoughts on how this is going to be tackled? Because we've already mentioned that there is a limited human resource in most places, right, to cater for this increasing population. Does someone want to speak?
You said there is limited resources, and when a person is already aged and when a person has cognitive issues, so at that time, agreed, we cannot tackle that problem. So that is why primary prevention. So as we know that there are various levels of prevention. So start it right from the beginning, when you know that aging is one of the risk factor for a person to have cognitive impairments or maybe other impairments. So we need to tackle the problems with the levels of prevention, so that the issues, as we know, that pre-geriatric training or maybe sensitizing them. What I read, I came across an article which stated that there is a age lab in US where they sensitize people. Like, it's a simulated area where you walk through that road or that lab, which exposes you to the scenario which will be when you age. So maybe you find that something is shaky around and not able to balance yourself. There is the surroundings is blurred, so they sensitize you. So if you do not take care of your health right now, after a few years, this is the situation what will happen. So you need to take care of your health. Start from the beginning. Prevention is better than cure, and it is also cheaper than cure. So start it from the beginning as soon as possible. We know that research says that even the dual tasking, multiple tasking becomes an issue right from the early 50s. So again, cognitive training, maybe mind mapping, all those things can be started.
Okay, so this is Faith. I'm from Uganda, and I've been exposed to the aging approaches being implemented in Minnesota, and what they do in order to ensure that the elderly are really taking good care of themselves. They have something called AG Physical Activity Program, which invites all the elderly for physical activity lessons and different exercises that should be suitable for them as regards to their age. But one of the centers that they are relying on to ensure that this is something that is sustainable and also filling the gap is partnership with religious organizations, partnership with fitness centers that are offering these services free of charge, and also linking them to care through the Minnesota health insurance plan for the elderly and the aged. So they've also done something called Walk With Me, whereby they've developed an app, and this is mainly to help engage the elderly in a more digitalized world, but also help them create a community of talking and also doing activities together. So they have an app, and then it sets them up to walk, and then you know the friends that you're going to meet, and then you go for a walk, meet somewhere, talk, and then each of you go. They've also introduced games to those, and one of them is Pokemon, which we used to play when we were young. But with this, through your journey as you walk on the phone, like there are places you stop and do activities together. So many of them are able to network and also be able to plan for their activities like the next day as a group, but linked through religious organizations, fitness centers, and also mainly financed by the Medicare plan. Yes.
Okay. So, is there someone else who wanted to say something before I move on?
I just want to share about solve the problem about the limited resource in caring our elderly community in Indonesia. We have a community health worker, and it is almost the same with a social health worker, and they're trained by primary health care, and because they are as a first gatekeeper in community, and they have a duty to find out like a health problem in the community, and then they will give a report to primary health care services. And they have so many activity to manage for the elderly community. Like we have a program like Posyandu Posyandu is a content of to screening for the elderly health, and yeah, it's the same of the like promotion and prevention activity like that, and controlling for their disease like that, and just make them to more disciplined if they have to drink drugs for curing hypertension or for especially for metabolic disease like that. So there are and beside that they ask for the elderly community to do like some exercises once a week like that, and then it is supporting. It is supported by our government. It's full of supported by our government. That's all.
Oh, that's wonderful. So in the next 15 minutes, as the network towards Unity for Health, are there any suggestions you think stemming from what we've discussed, or other suggestions we could try to push forward as the network as we carry on, you know, our mandate, which is to improve community care for the elderly? I had mentioned that we try to do training for the medical students, but I don't think that may be universal as yet, and that in addition, the medical educators also play a role in getting to learn what to do and taking it back to their mother institutions. Are there suggestions of how we can push the agenda for the elderly forward? Fitriana, do you have any?
Yeah, in our country we have a curricular program for the undergraduate health students, It's a program name of Interprofessional Education Collaboration Practice, and there is a team in geriatric care. So in my institution, we have three study program: medicine, health nutrition, and nursing. And the students, one team contain of the three study programs, and they work together and go to the community, and especially for the geriatric community. And beside they visit them, they give some like simple intervention for the promotion and prevention for the elderly community. And they give some like they make some like a simple activity too for the geriatric community. And
okay.
And after that activity, and at the end of that program, they will assess. So from the interprofessional education collaboration practice, how it can increasing of the patient experience. So when the patient experience increasing, it will be make like cost effectiveness. And for the student, they will realize of the teamwork is important, communication interprofessional is important, and the value and or ethic will run among them, and then they can realize of the role of responsibility of its profession through that activity. And in that activity, there is a supervisor and facilitator from the primary healthcare who assess them, how they work, how activity is running well like that.
Okay, so 2 points from you about interdisciplinary training, as well as emphasizing primary healthcare services. And I think Riddhi is also suggesting the same, but she pointed out something about appropriate exercise. Riddhi, do you want to say something about appropriate exercise for the elderly?
Yeah, so according to World Health Organization and ACSM, they have designed the exercise prescription. So over here we know that for geriatrics, we need to, along with the physical fitness tests which we do for adults, like increasing the strength, stamina, flexibility, aerobic capacity, along with that for geriatrics we need to strengthen the skill related components. Now in the skill related components, there is balance, reaction time, agility, coordination, because these things get affected because of the physiological changes. Now you would say, why agility, why coordination? That might be required in sports, but then in sports they need it for sports, that is agreed, acceptable. But then for geriatrics, the agility gets affected. Maybe getting up from chair, walking 10 meters and again sitting back to the chair might also be an issue. So that is might be affected. So we need to do skill related training, and also along with it cognitive. So exercise prescription. So according to the guidelines of World Health Organization and ACSM, be it for healthy aging exercise prescription or maybe for diabetes, hypertension, the World Health Organization says minimum 150 minutes of exercises per week is advisable. And each component, maybe it's strengthening, it should be done 2 to 3 times per week. Flexibility training should be done at least 3 times per week. So cumulative and the exercise prescription, because there are many do's and don'ts. So that exercise prescription plays a very important role. As we know that medicine prescription should be according to the dosage, according to the age. Accordingly, exercise prescription is tailor-made. So a person's current health status is taken into consideration and exercise is prescribed for that. Also, what I would like to add, we have manpower issues and all. So again, 2 points what I would like to add is, we know that there might be old age homes and maybe orphanages all around the world or across the world. So maybe the bridge can be, the gap can be filled by maybe allowing geriatrics and the orphanage kids to meet, because what each people require is tender love and care. So if that gap is covered, that will be one of the great step where kids have grandparents or maybe someone similar to grandparents who guide them through the life cycle or maybe lifespan, and geriatrics have people who will, maybe as we discussed earlier, maybe that loneliness and thing can be taken care of. Also, the second thing, maybe there is something on a CSR, that is corporate social responsibility. As as various multinational companies are picking up maybe small villages, they can also have geriatric home under them, and they can maybe just have once in a month visit to that geriatric home, or maybe going there and meeting them, just meeting them and hi hello and spending time with geriatric like eases their pain. Thank you.
Okay, thank you. Do other participants have suggestions of what, as a network, we can try to move forwards as an agenda?
Yes, so I was thinking as we move forward, we should carry an agenda that involves supporting country planning and actions, especially ensuring that countries get the skills and tools they need to create policies that are favoring healthy aging and also living long and decent, healthy lives for the aging. As per the African setting, really, we don't really have a lot of policies that and tools coupled with skills that we need to advocate for this. So if the network could really support country planning and action in line to healthy aging as per the WHO agenda, that would be something that is great.
Right. I would have to have champions in each of these places.
Yeah.
So, because I wanted to know how much penetration we continue to have in other institutions that are not yet part of the agenda. Elsie, you can comment on this?
Well, for the time being, I think this is a good start. We can really try to get, first of all, to the members that are on the task force and those that have attended this webinar, so that we can try to start from this group to embrace what faith is saying. And in our, when we have a meeting in Darwin, we can expand our agenda and talk to more people about this. Thank you.
And I would also comment that, for the last comment by Faith, I think one of our strategies is to strengthen each of the regions, which our definition of strengthening each of the regions is enrolling more institutions, but also thought leaders, with the idea that we need to help build the capacity and knowledge of the local actors so they can drive this system and policy change locally. And so we're serving as that link between WHO and maybe these regional actors. So that's part of our agenda, is to really focus on these regions so that the work can be done. And elderly care is, of course, as everyone knows, one of the pillars that we need to focus upon.
Focusing on prevention, also look after the health promotion, which was being posted by World Health Organization at Ottawa Charter. Health promotion and the strategies. So we can promote health at each and every point. And also looking at I would like to introduce one term, that is slippery slope of aging, which has 4 parts in it. That is fun, function, frailty, and failure. So as we age, there is a slope. So we need to decide where we want ourselves at. Is it at fun? So where a person is really active, having all activities and community participation is there. function is only able to maybe do some of it and taking care of himself. Third is frailty, where maybe he requires some of the other assistance, and failure is totally dependent on someone. So at each level, we can have a program where entire healthcare team or rehab team can participate and give our best, so that each geriatric person has a better health, optimal health. And according to World Health Organization, it says absence of physical, mental, and social well-being. But there is another insight to it, where the concept of wellness plays a very important role, where it is not only just about physical, mental, and social well-being. There are domains inside it, where under social there is also vocational area, where a person being geriatric, he still might have want to work, but then whether actually community is allowing him, or whether actually can do it, that depends on the policies and also the fitness of this. Also spiritual, mental, and intellectual and cognitive well-being. So overall, wellness should be a target, where we want to improve wellness of each and everyone.
We conclude with an appreciation of how we have to address all those areas. We should keep in mind the issue about the limited human resource, and how we can get on board people who may not exactly be experts in those fields, but see how we could make use of them through community volunteers or other groups of people within the community who can help promote.
There's also a comment from KU. It says, in addition to training medical students in the care for elderly, children should be thought about care for the elderly. This should be incorporated into training curriculum up to tertiary.
Yes, so the first point was on the interdisciplinary training and service for the elderly. Anything else?
I think the effective team-based healthcare through the interprofessional collaboration among healthcare providers is really important to face complexity of a problem in elderly, to improve the quality of care and patient outcome. And inappropriate geriatric care can lead to decreasing quality of care due to hospital readmission and medication error caused by lack of communication, which adversely affect in patient outcome like that. So I think educational program about for the interprofessional education is essential to prepare in health students, because the IPE can ideally share appropriate learning approach and have prepared a student for the collaborative practice in the future. And it can support for the elderly care like that.
Okay. Right. If there's no other points, I would like to thank all of you for your having a spare time to participate in this virtual symposium as we gear up for the future, but also as we gear up for the 40th anniversary for the Network Towards Unity for Health. And we hope that in the future we can get to realize more work from the points that we've discussed that will help to promote the well-being of older persons. I thank you for your participation. Nick, any last words?
Nope, just wanted to thank all the participants. We will continue this work. And thank you, Noeline, thank you, Riddhi, and thank you, Fitriana, for serving as moderator and panelist. We appreciate it.
Thank you for organizing it, Nick.
Enjoy your evening, morning, or afternoon. Bye-bye.
You too. Bye-bye.
Bye. Thank you.